Welcome to the American Brain Tumor Association's free educational webinar series. Thank you for participating in today's webinar. Today's webinar is on chemotherapy for brain and spine tumors. Why do we use it and what to expect? The webinar will be presented by Dr. Marta Penas-Prado. Please note that all lines during our webinar today are muted. If you have a question you would like to ask, type and submit it using the question box in the control panel on the right-hand side of your screen. Dr. Penas-Prado will answer questions at the end of her presentation. In the next few days, you will receive an email asking you to take a brief survey to evaluate this webinar. Please take a few minutes to share your feedback, which is important to us as we plan for future webinars. Today's webinar is being recorded. The recording will post to the ABTA's website on the Anytime Learning page shortly. Registered participants will receive the webinar recording link in a follow-up email message once it is available. Let's pause for a moment so that we can begin our webinar recording here. The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss chemotherapy for brain and spine tumors, why do we use it, and what to expect. This webinar has also graciously been sponsored by Arbor Pharmaceuticals. My name is Christine Daly, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Marta Penas-Prado. Dr. Penas-Prado graduated with a medical degree from the Universidad de Santiago de Compostela and completed a neurology residency in Madrid, Spain. She completed her Neuro-Oncology Fellowship training at the University of Texas MD Anderson Cancer Center in Houston, Texas. Prior to joining NCI, Dr. Penas-Prado was Associate Professor and Clinical Research Director of Neuro-Oncology at MD Anderson Cancer Center, where she joined the faculty in 2011. Currently, she serves as an Associate Research Physician at NOB NCI. She specializes in rare CNS tumors. Her research focuses on developing clinical trials for primary brain tumor patients. Thank you for joining us. You may now begin your presentation.
Thank you so much. Good afternoon, everyone, and thank you for your kind introduction. We're going to talk today about chemotherapy for brain and spine tumors, why do we use it, and what to expect. This is a really broad topic, and we're going to cover 6 different areas. First, we're going to talk about how our brain and spine or central nervous system tumors treated. Then we're going to explain what is chemotherapy. Then we'll explain why do we use chemotherapy to treat CNS tumors. Next, we'll talk about what to expect if you are receiving treatment with chemotherapy. Then we'll cover a very important topic, which is the differences between standard treatment and experimental treatment. And then finally, we'll talk about what to ask if you are going to start chemotherapy. So how are CNS tumors treated? Well, there are 3 main components of therapy that include surgery, radiotherapy, and chemotherapy for most patients, with very few exceptions. Patients with brain and spine tumors need to receive a combination of one or more of these different therapy modalities. Chemotherapy is one of them. Different from surgery and radiotherapy, chemotherapy has a more extensive effect in the entire brain, the entire spine, and the entire body. Surgery and radiotherapy are more focal treatments. Very importantly, we'll see how clinical trials are critical to find better treatments for present and future patients with brain and spine tumors and to advance the field. And I also want to start by explaining that treatment of CNS tumors is multidisciplinary and individualized. What does that mean? Multidisciplinary means that it's really a team effort. Multiple different healthcare providers are involved in taking care of patients with brain and spine tumors. And what does individualized mean? Well, it means that it needs to be adjusted to the patient characteristics and needs, like the age of the patient, the location of the tumor, sometimes the molecular features of the tumor, etc. So, what is chemotherapy? Again, chemotherapy is a very broad topic. We could talk about many different aspects of chemotherapy, but in a very simple way, chemotherapy is a type of cancer treatment that uses drugs to kill cancer cells. We'll cover many of the basic aspects of chemotherapy to treat brain and spine tumors today, But if you want to find more information, you can go to places like the NCI website. So what types of chemotherapy do we use to treat brain and spine tumors? We can find three main different types. One is classical or cytotoxic chemotherapy. Cytotoxic basically means toxic to the cells. And there are multiple chemotherapy agents, but there are not so many that are used to treat brain and spine tumors. And I have a list here that includes most of the agents that are used to treat this type of tumors. Temozolomide, lomustine, or CCNU, commonly used in combination with two other drugs called procarbazine and vincristine in a regimen called PCB, carmustine or BCNU, irinotecan or CPT11, and then others like cisplatin, carboplatin, ifosfamide, cyclophosphamide, etoposide, that are used more rarely but have an important role in treatment of certain rare CNS tumors like embryonal tumors. Then there are also some other drugs that are also called chemotherapy in a broad sense, although sometimes this can become a little confusing. One of them is targeted therapies. We'll see in the next slides what this means. The only targeted therapy that is approved for treatment of CNS tumors at present is everolimus, and is approved for the treatment of a very specific tumor called SEGA, subependymal giant astrocytoma, that happens in patients with a genetic disorder called tuberous sclerosis. A special type of targeted therapy is antiangiogenic therapy or antiangiogenic drugs. The only one that is approved for treatment of CNS tumors at present is bevacizumab for the treatment of recurrent glioblastomas. We'll also see what these drugs do to tumors. And finally, also under the umbrella of immunotherapy, some of the medications used as drugs are also considered chemotherapy in a broad sense because they are drugs given to patients. And I'm listing here three of them that have commercial names because they have been approved for treatment of other cancers. But I want to also make a comment on how these immunotherapies are still not standard therapies for brain tumors, are only using as experimental treatment in clinical trials. We'll see later on how important it is to make this distinction between standard versus experimental treatments. So what is classic or cytotoxic chemotherapy? What you see on the slide right now is the normal cycle of any cell in our body, including tumor cells. And cells go through different stages of synthesis of DNA and proteins, and growth, and mitosis or cell division. And cytotoxic chemotherapies work on different points of this cycle to basically injure the cell in different ways and stop the division and growth of the cell. Some of them are specific to certain parts of the cycle, and some others act regardless of the cycle, the point of the cycle where the cell is at that moment. So one example of classic cytotoxic chemotherapy is temozolomide, a drug that is used very commonly to treat primary CNS tumors. The temozolomide enters the tumor cell as an active metabolite, but then goes into the nucleus and causes damage to the DNA by adding methyl groups. When this happens, the DNA breaks and the cell is unable to repair the damage to the DNA and finally ends up dying, a process that we call apoptosis. Next, we'll talk about what targeted therapies are. So basically what a targeted therapy is a treatment that tries to block a specific process that the tumor cell uses to survive. Tumor cells are very proficient at proliferating without much control. They can go through the cell cycle without listening to the normal stop signs to stop tumor proliferation, and they are somehow protected against the normal cell death that happens to all other normal cells. So what targeted therapies do is to try to block these pathways at different levels. And this slide summarizes the targeted therapies that have been tested in brain tumors so far. Again, as a reminder, the only one that has been approved up to now for treatment of brain tumors is everolimus for a very specific type of tumor called SEGA. All the others are still, many of them, on clinical trials trying to determine their role to treat glioblastomas and other brain tumors. So antiangiogenic drugs are a specific type of cytotherapy. And how do they work? Well, brain tumors, the same as many other tumors in the body, are able to send signals to blood vessels to proliferate and create new blood supply to the tumor so it can continue to grow. And the way tumors do this is by sending certain signals, certain proteins to the vessels so they can react and grow and provide blood supply. There are certain medicines called antiangiogenic drugs that stop this process that we call anti-angiogenesis. For example, VEGF inhibitors, VEGF stands for vascular endothelial growth factor, they stop this process and therefore try to starve the tumor from new blood supply. Bevacizumab is an antiangiogenic drug that is approved for recurrent glioblastoma, and we can see an example here of an MRI of a patient treated with bevacizumab with decrease in the tumor size on this MRI after treatment. Of course, this doesn't work as nicely as we've seen here in every single patient, and there are actually reasons to believe that part of this effect on tumors is due to the effect on the tumor vasculature, letting less contrast leak out from vessels, and therefore making the MRIs look better when really there's not necessarily an effect on the tumor growth. Immunotherapy on the other side is a really big box. It can get really confusing sometimes. I'm frequently told in clinic by patients and their caregivers, can I receive immunotherapy? Immunotherapy is not just one drug or one big way to treat cancer. It's actually a fairly complex number of therapies that can be used to modulate the immune system. We can broadly divide immunotherapy into active immunotherapy. This is drugs or other ways that we have to stimulate the patient's own immune system to fight against the tumor. And then we have other types of immunotherapy that are passive. Basically means we are delivering compounds or cells that are from the immune system produced at least partially outside of the body and then infused back to do some effect on tumor cells. So why are we including these under chemotherapy? Well, this is because some of these immunotherapy treatments are actually drugs that can be given and can modulate the effect of the immune system against the tumor. We call them checkpoint inhibitors, and oftentimes we refer to them as chemotherapy as well. So I'm being told there are difficulties to hear me. I'm going to change the voice system to the phone.
Just 1 second. Dr. Penas-Prado is going to call in so that everyone can hear her a little bit better. So we'll just pause for 1 moment until she's able to get back on.
Hello?
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 Yes, we can hear you. Are you on your phone?
Excellent. Yes, I'm on my phone now.
Can you hear me well now?
Yes, if you could say one more thing so we can test it out.
So testing, can you hear me well?
Yes, that is much better. Thank you.
Okay, fantastic. Yeah. Sorry about that. We'll try to continue now that we have a better sound connection. So we were talking about how immunotherapies are a very complex group of therapies. Some of them can be considered chemotherapy because they are drugs given to modulate the immune system. Yes.
I think, can you actually mute your microphone on your computer, because it's now echoing?
Yes, it's done. All right. Okay, thank you so much. Can you hear me well now?
Yes, that is perfect.
Fantastic. Okay, we'll continue then. So once we have reviewed what types of chemotherapy we have to treat brain and spine tumors, we're going to talk a little bit about how chemotherapy is given. And it really depends on the specific type of chemotherapy. Some chemotherapies are given orally, some others are given intravenously, some others are actually delivered into the surgical cavity with wafers, and some others can be given inside the cerebrospinal fluid via spinal taps or with what we call an Ommaya port on the head. So this really depends on the type of drug and also the type of disease for which the treatment is being used. Intravenous chemotherapies can be given sometimes by a catheter in the arm or sometimes with a port in the chest. And depending on the type of chemotherapy, some of them will be given at home, just to taking the pills at home. Some others will be given in an outpatient clinic or during a hospital admission, for example, for patients with primary CNS lymphoma or certain embryonal tumors. A hospital admission is required because these chemotherapies need to be given with certain preparation, IV fluids, etc. An important concept I want to touch on is what is a cycle. This can be sometimes confusing when you are not used to chemotherapy terminology. So what a cycle is the time period over which chemotherapy is given, including rest periods. And the reason why chemotherapy is given in cycles is in part because we want to allow the cancer cells to be attacked at their most vulnerable times during their cycle of life. And we also want to allow the body's normal cells time to recover from the damage from chemotherapy. So, for example, for temozolomide is typically given for 5 consecutive days, and then we have 3 weeks of rest, and we repeat that every 4 weeks. So we call this 4 weeks one cycle. For another medicine, lomustine is given in only 1 day at the beginning of the cycle, and then there's a rest period of 6 weeks, and we call that one cycle. And for example, for bevacizumab is given intravenously every 2 weeks, and we call one cycle 2 of these doses. That means 4 weeks of treatment. So why do we use chemotherapy? We so far reviewed what types of chemotherapy are available, how chemotherapy is given. Now we're going to review a little bit why chemotherapy is given. What is the benefit? Why do we even use it? And for that, we're going to focus on 6 specific CNS tumors that in which we know that chemotherapy provides a benefit. These are going to be glioblastoma, anaplastic astrocytoma, anaplastic oligodendroglioma, low-grade gliomas, medulloblastomas, and ependymomas. And before we start, I want to explain a little bit how do we measure success in oncology. And the way we do that is by using statistics. So as you all know, statistics are good to predict results in large groups of people or in large number of events, but they are really not very good to predict each and every case. This is very important to keep in mind when trying to analyze the results of treatments or any type of treatment for cancer or for any other disease. So just as a brief introduction, if you're not familiar with this, the usual way in which we explain the results of chemotherapies by using these special statistic curves called Kaplan-Meier, and we look typically at 2 parameters. One is called progression-free survival, or PFS, and the other one is called overall survival, or OS. So in glioblastoma, for decades, the treatment that is being given to these patients has been surgery and radiation upfront, followed by chemotherapy at the time of tumor recurrence. However, in 2005, the results of a large phase 3 clinical trial were published, and it was demonstrated that there was a benefit when chemotherapy was used up front in combination with radiation, in this case, temozolomide. So this became the standard of care. And from that point on, glioblastomas are typically treated with a combination of radiation and temodar upfront. With some exceptions, as we said, therapy needs to be individualized, and sometimes some patients require adjustments to this regimen. In anaplastic astrocytomas, something very similar has happened. Also for decades, there's been a lot of debate about whether or not they should be treated with chemotherapy up front. And last year, the interim results of a phase 3 trial were presented, and it was seen again that there was a benefit of adding temozolomide to radiation for newly diagnosed anaplastic gliomas. We can see in these survival curves how the probability of progression-free survival and survival is increased when temozolomide is added to radiation. In anaplastic oligodendrogliomas, once again, similar results. Two recent phase 3 trials published in 2013 demonstrated that the combination of radiation and chemotherapy, this time the combination of 3 agents, procarbazine, CCNU, and vincristine upfront, improved outcome as compared to using radiation alone. In low-grade gliomas, similarly, in certain patients with low-grade gliomas with incomplete resection or with age more than 40, the combination of radiation and chemotherapy with PCB also improved the results as compared to radiation alone. We'll finally review two tumor types that are less frequent than gliomas, but in which chemotherapy has also a role. Medulloblastoma is one of them. Medulloblastoma is a very frequent tumor in children, the most frequent malignant brain tumor in children. However, it's a rare tumor in adults. Approximately 200 new cases are diagnosed each year in the United States. So that means that it has been really very difficult to examine what are the best therapies for these patients, since the number of patients is very small and developing clinical trials is extremely challenging. But there is some data that was published recently in 2015 and 2017 looking at large cohorts of patients with adult medulloblastoma treated either with radiation alone or with radiation and chemotherapy. And these studies demonstrated also a benefit of chemotherapy compared to radiation alone upfront. As always, it's important to keep in mind that treatment needs to be individualized, and sometimes the combination of treatment is not the best approach for all patients, but this data is nevertheless very important. Finally, ependymoma is also a rare CNS tumor that can happen in the brain or in the spine or both. And until very recently, there's been also a lot of debate about what the role of chemotherapy is for treatment of this disease. Usually, ependymomas are treated with surgery and or radiation. Chemotherapy has been reserved for tumors that do not have options of surgery or radiation. And a recent clinical trial determined that the combination of temozolomide and lapatinib, a targeted therapy, has actually a role to treat some patients with ependymoma. And these results were recently presented at the Society of Neuro-Oncology meeting in November this year. And there were a number of patients treated on this trial, a total of 50. And of them, one of these patients had a complete response of the tumor while on therapy. There were 4 patients with a partial response and 33 patients with stabilization of disease. And many patients with spine tumors and with brain tumors actually had improvement of their symptoms. So based on this data, for the first time, it was possible to demonstrate prospectively that chemotherapy can have a role for the treatment of recurrent ependymomas. So now that we reviewed what types of chemotherapy are out there and why do we use chemotherapy, what to expect from chemotherapy? What happens when we are on chemotherapy? Well, a very obvious thing that happens when we are on chemotherapy is that there is potential for side effects. And this is in no way unique to chemotherapy. Any type of treatment for any type of disease, including not only drugs, but also surgery or radiation, even including treatments that are considered alternative treatments or herbal remedies, all of them, many of them have potential for side effects, sometimes serious. So in that sense, chemotherapy is not unique. What is really important is to know what these side effects can be and monitor for them to detect them early and to minimize the side effects. Chemotherapy definitely affects people in different ways, and not everybody gets the same side effects or to the same degree. So your medical team will be the best resource to discuss with you the benefits and risks of chemotherapy in your particular case. In this slide, we're going to list some of the common side effects from chemotherapy, particularly side effects that are more common in patients with brain and spine tumors. But once again, I want to remind everybody that this is not a list that implies that everybody is going to get these symptoms. It only implies that these are possible side effects from chemotherapy, and it's important to discuss with your healthcare team which of these side effects are expected to happen and how to treat them or prevent them. So nausea and vomiting, constipation, and loss of appetite are fairly common. Fatigue is also a common side effect from chemotherapy. Low white blood cell counts and risk for infections and low platelet counts with potentially associated bleeding problems and low red blood cell counts and anemia can happen with chemotherapy. And this is the reason why monitoring with blood work is so important to detect any drop in these numbers early and implement measures if needed, like, for example, holding chemotherapy or reducing the dose or giving supporting treatments. Fertility problems and congenital abnormalities can happen, and this is why it's so critical to avoid pregnancy while being on chemotherapy. Finally, there are some other side effects that tend to be less common in patients with brain and spine tumors, given the type of chemotherapies that are used. But again, depending on the specific agent, we can see side effects like diarrhea. This is a typical side effect from a chemotherapy called irinotecan. Hair loss is fairly infrequent, but some treatments like etoposide can cause hair loss. Hearing impairment can happen on patients treated with cisplatin. And then damage to sensory and motor nerves, what we call peripheral neuropathy, can also happen in patients treated with agents like, for example, cisplatin or vincristine. What about the common side effects from targeted therapy? Well, targeted therapy is supposed to work, as we said, on very specific proteins, receptors, pathways. However, these proteins, receptors, and pathways are also present in normal structures of the body. So the effects of these targeted therapies are going to depend on the specific drug and the specific target and where that target is present. For example, for EGFR inhibitors, the epidermal growth factor receptor, that's what EGFR stands for. This receptor is present also in the skin, in the bowel, in the livers, in the lungs. And that's what explains what type of side effects we can see, like rash, changes in nails and eyelashes, diarrhea, liver inflammation, and rarely also problems with lung inflammation or pneumonitis. Another example is the agents that target this protein called mTOR. This mTOR protein is critical for many functions of the body and is present also in the skin, in the bowel. It also affects the function of the immune system and is also involved in metabolic pathways. So that's what explains the specific side effects from these medications, which include, for example, also rash and others like, for example, high glucose or high lipids. We're going to talk also about vascular endothelial growth factor inhibitors and where are these found? Well, these are found in blood vessels. So the side effects are going to be related to blood vessels. We're going to take the example of bevacizumab and the most frequent side effects from bevacizumab since it's an approved drug for recurrent glioblastoma. The first thing to know is that it's very rare to see nausea or vomiting or low blood counts with bevacizumab. These are not frequent side effects from this drug, except sometimes rarely low platelets. What we see commonly are symptoms that are usually mild and easy to control, like fatigue or high blood pressure, typically when bevacizumab is used in the long run. Really, it's usually easy to control, but if it's left untreated, then it can lead to more serious complications in the kidney or in the brain. Then there is a group of side effects that are a lot less common, but can be serious and potentially even life-threatening, like clots in the legs. That's what we call DVT, or deep venous thrombosis, or clots in the lungs. That's what we call PE, or pulmonary embolism. And then clots in other more unusual organs, like, for example, the brain, causing a stroke, or the heart, causing a heart attack. Those are a lot less common, but possible. There's also the potential for bleeding complications, hemorrhagic complications, and there's also the potential for a rare complication called bowel perforation. So all of these side effects are really related to the effect of bevacizumab on blood vessels. And as we said, some of them are common and expected and usually typically easy to control, and some others are less common but can be more significant. There's also another side effect that can happen and is probably quite underreported because most people do not think that it may be related to the treatment, and is dysphonia or hoarseness. And this is due to an effect of this antiangiogenic agent on the blood vessels in the laryngeal apparatus. So what about common side effects from immunotherapy? I'm going to refer here specifically to checkpoint inhibitors, these drugs that work on the immune system. And the way they do this is by releasing the brake. So I'm going to explain what this means. Usually, tumors, including brain tumors, are able to send signals to the immune system to actually stop recognizing the tumor as something that the immune system should take care of and get rid of. So what checkpoint inhibitors do is to release this brake. And by doing that, they try to stimulate the immune system to kill tumor cells. But at the same time, the immune system can also become reactive against other organs of the body. And there are certain toxicities that are more common, like, for example, in the skin, a rash, or in the lungs, causing inflammation, what we call pneumonitis, or in the bowel, causing diarrhea, or in hormonal glands, like the thyroid gland, the adrenal gland, the pituitary gland, causing hormonal treatments. Those are by far the most frequent side effects. Again, they do not happen to everybody, but they can happen. And then there are some other rare side effects that can happen in other organs, causing inflammation on multiple other levels. What is also important to remember is that most of these side effects are reversible, but early recognition is definitely critical. The same as proper treatment is really critical. So we spoke about what type of chemotherapies we have available, what are the side effects, why do we use them, but it turns out that there are certain limitations of chemotherapy when treating any type of cancer, but also specifically brain tumors. One of these limitations is that some drugs have poor penetration into the tumor through the blood-brain barrier, or also in areas of hypoxia or due to increased intracranial pressure. These drugs can have difficulty to enter the brain tissue. Then another limitation is the toxicity in other parts of the body, what we call systemic toxicity. For example, serious myelosuppression. This means decreased bone marrow activity and therefore low numbers of white blood cells, red cells, and platelets in the peripheral blood. There's also the issue of interactions with other drugs that are commonly used for treatment of brain tumors, like steroids or certain anticonvulsants. And finally, there is oftentimes resistance of brain tumors to chemotherapy. One example is the overexpression of this protein called MGMT that can happen in glioblastomas. It actually happens in most of them, in 70% of them. And this protein can actually protect the tumor cells from the effect of chemotherapy and make them resistant. And finally, there's also tumor heterogeneity. This means that every tumor is different. Some tumors, despite having the same name, respond differently to chemotherapy. And also inside the same tumor, there may be cells that are sensitive to certain treatment, and there may be others that are resistant. So it's because of all of these limitations that we focus so much effort on developing better treatments, and we do that by testing new treatments or experimental treatments in clinical trials. So here's the important distinction between what is standard treatment and what is experimental treatment. Standard therapy basically means a treatment that has been previously studied, approved, and used for a given indication. Therefore, the probability of response, the risks, the safety are well known. We know more about that medication. It's also important to remember that despite these limitations, standard treatments are not a synonym of useless or not effective. Certainly, they have specific roles in certain tumors and at certain times. So we should not just think that because we call them a standard, they are completely useless. They have their applications. Now, what are experimental therapies? Well, experimental therapies have not completed yet all the steps to fully understand the efficacy and safety of these medicines. And patients on clinical trials may or may not benefit from the treatment being studied despite all the good science that is performed before even a clinical trial is started. Therefore, we know less. But even if we know less, we know a significant amount of information about these experimental medicines before we start a clinical trial. And importantly, we have to remember that our current standard treatments were clinical trials in the past, and the current clinical trials will lead to future standard treatments. So this is why they are so critically important. In any case, every person is different, and your medical team will be well qualified to determine if a standard or experimental therapy is the most appropriate alternative for you. So let's explain a little bit more what a clinical trial is for those of you who may not be familiar. A clinical trial is a system to improve the results of a standard therapy by testing experimental treatments. And oftentimes we think that clinical trials involve chemotherapy, but certainly they can also involve other treatments. First of all, they can involve chemotherapy in a broad sense, so that also includes certain immunotherapies, etc. But also can test sometimes surgery, devices, radiotherapy, or combined modalities. So it's not only about chemotherapy. And the objective is always to determine if a promising new drug, device, radiation, or a new combination of treatments can pass the test to be declared a new standard treatment. So what this is going to require is to test both the drug's safety and also the efficacy in a scientific and well-supervised, safe way, while also getting the most information possible so we can continue to build on this knowledge, following a written protocol. So clinical trials are then aimed to develop better tolerated and more efficacious treatments against brain tumors, and this is why they are so important. So we're going to enter the final part of the talk, and we're going to talk a little bit about what to ask. Well, first of all, I want to say that it really helps to be prepared. So certainly it can be overwhelming and really hard to remember all these details that the healthcare team is sharing with you about your diagnosis, your treatment, the side effects, the treatment schedule. So always try to bring someone with you if you can to your visits, or ask someone to join on calls. Try to take notes or ask the person with you to take notes. Ask for breathing instructions or materials so you can review them later when you are more relaxed at home. Repeat the instructions as you understand them to make sure that you are on the same page with your healthcare provider. Ask who's the contact if you have more questions when you arrive home, and what is the number or the email to contact the team. And importantly, if you have problems to remember or to communicate or understand what is explained to you, then try to decide who will be the primary person communicating with the doctor, and try to keep one designated person to do this so the message is consistent. So some examples of what are relevant questions that may ask you to understand better what are you going to receive and to expect during chemotherapy treatment. Is this a clinical trial? Is this experimental treatment? Or is this a standard treatment? And if it is a clinical trial, what phase of a trial is this? And what is the goal of the study? What we are trying to test with this study? What is the treatment plan schedule? How often the treatment is given? How long the duration of each treatment is? Importantly, can I drive myself after treatment? Am I going to feel well enough to drive? Are there any other special precautions that I should follow after treatment? Anything that I should watch for? When do I have MRIs done? How often the MRIs are going to be repeated to see what the effect of the treatment is? And what do you expect from the MRIs? Do we expect perhaps to see stability of the tumor? Do we expect that perhaps we will see a response? All this is going to depend on the specific tumor being treated and the agent being treated. What are the side effects and what can I do to prevent them if there's anything I can do? And there are many supportive medicines that can be used to prevent side effects these days, so what should I be taking? What do I need to report to you in terms of side effects? For example, fever is a good example of something that needs to be reported. How and who do I call if I have problems? And can I continue my normal activities? And finally, can I have this information in writing? This is going to be extremely helpful. Once you can relax and be at home and with your family, you can review all this information again. What to ask if you are considering a clinical trial specifically? Well, first of all, remember you are part of the research team. You are a very critical person in the team, and you have the right to ask all the questions you may need to make your informed decision. So first is, am I eligible for a clinical trial or for a specific trial that you may have in mind? What is the treatment? How long will the clinical trial last? How do researchers think the experimental treatment differs from my current treatment? How will I know if it's working? What are the pros and cons of being on this therapy as opposed to perhaps another experimental therapy or a standard treatment? What risks could I face in this trial? And finally, I want to dedicate the last slide to some piece of advice. Information is power. It's really important to be well informed about your disease and your treatments, but you also have to be careful with your sources and understand where your sources come from. The internet is a very powerful tool, but sometimes what we found in the internet is not necessarily accurate, sometimes it's misleading or it's just wrong. So it's important to always use trusted websites. Remember that in many instances, in many websites, the information is not really vetted. And the first or the top sites may not really be the best sources for information. It's important to be careful and keep your privacy. And always feel comfortable asking your healthcare team about anything that you may have read online. Always have that filter with your healthcare team. They can help you understand if that is a reliable source and what is true and what is not true about what you read online. Well, this is all for my presentation. I'll be very happy to answer any questions, and thank you so much for your attention.
Thank you, Dr. Penas-Prado. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. We do have a couple of questions already, so we'll start with the first one, which is, what is generally recommended for glioblastoma multiforme that progresses after surgery, radiation, and Temodar?
Right, that's an excellent question. And it really depends on the specific case. It's very difficult to give just a general advice on what is the next treatment that should be used. But what I typically recommend my patients is, if it's at all possible, look into the possibility of clinical trials. Clinical trials are not an option for everybody, and as I said earlier, your healthcare team should be explaining to you what is the best option for you. But it's always worth considering and asking whether a clinical trial is a reasonable option, because these tumors tend to be very resistant to treatment, and the role of standard chemotherapies and repeated surgeries and repeated radiation, they can control the tumor for some amount of time, but we want to find better therapies, and these better therapies are today in clinical trials and will be the treatments of the future.
Thank you. And the next question is, how do you decide whether to use Temodar or PCV? Is the side effects the main determining factor for that?
That's an excellent question. And it is true that in general, temozolomide is better tolerated, that this combination of these three drugs, P, C, and V, procarbazine, CCNU, and vincristine. So it really depends on the type of tumor. For example, in glioblastomas, the effect of temozolomide against the tumor seems to be more potent than the effect of PCV. In other tumors like low-grade gliomas and anaplastic oligodendrogliomas, there is data demonstrating that using PCV combined with radiation is better than using radiation alone. And there is very strong data supporting this. But when these trials were designed, temozolomide was still not really used as much as it's used today. It was still not approved for the treatment of glioblastoma. There was not so much experience. So the trials were designed with PCV. And the question still remains whether temozolomide is equally effective or not than PCV. And there is actually a clinical trial going on now that will hopefully answer that question for anaplastic oligodendrogliomas, but we will not have the results until several years down the road. So the actual answer to this needs to be discussed based by case with your provider.
Thank you. And the next question is about chronic fatigue and how long somebody should expect fatigue to last after finishing chemo. There's also a similar question asking about chemo brain and how long that is expected to last after chemo is over.
Mm-hmm. Yeah, great questions too. So fatigue tends to be a symptom that happens especially in patients who receive treatment not only with chemotherapy but also with radiation. When it happens during this first phase of treatment, for example, for glioblastomas, they are treated with radiation for 6 weeks and chemotherapy in addition to it during these 6 weeks. We typically see how fatigue tends to be worse towards the end of this 6-week period of time and then slowly starts to improve after. In terms of when it continues to improve after completing chemotherapy, I've seen patients starting to feel improvement maybe 1 month down the road, a couple of months down the road. They tend to start to feel better once they complete chemotherapy. And I'm sorry, the other question was?
About chemo brain?
Oh, chemo brain, that's right. So chemo brain is a very interesting symptom that is actually quite difficult to really investigate in brain tumor patients. Chemo brain is a concept that comes from the treatment of breast cancer patients and others, that in which is a lot easier to identify the effect of chemotherapy on cognition. In brain tumor patients, there are so many factors that can induce brain dysfunction, like the tumor itself is growing in the brain. There's the effect of surgery, there's the effect of radiation. So it's really very difficult to tell if chemotherapy has a specific effect on that cognition. There are also many other medications that can cause problems with cognition, like anticonvulsants. So it tends to be very, very difficult to isolate the effect of chemotherapy from everything else. In general, we think that there's not a very large component of chemo brain on patients with brain tumors, and these other factors play also a very important role. But again, it's extremely difficult to do research on this field.
Thank you. Our next question is asking if you would add anything to the information that you've already shared or any guidance or advice when it comes to using chemotherapy to treat pediatric brain tumors. Or with a child with a low-grade glioma. So
I guess the question is for treatment of low-grade gliomas in pediatric patients. Is that the question?
Specifically for more in a general state, just pediatric patients, whether there's anything that you would change.
Yeah. Again, it also depends on the type of pediatric tumor. There are pediatric tumors that are very sensitive to chemotherapy, like medulloblastoma is very sensitive to chemotherapy, and chemotherapy definitely has a role for patients with medulloblastoma. Then there are some other tumors that are not really very sensitive to chemotherapy, like for example, pontine gliomas. That's a much more difficult tumor to treat with chemotherapy. In that regard, I think, for example, for pontine gliomas, what is really important is to look into research therapies moving forward to try to find better therapies.
Thank you. The next question, and you've already answered this a little bit, but I've got a question about the long-term effects of radiation and chemo treatment, and whether or not there's anything that can kind of help or assist any of those long-term effects.
If there's anything that can treat these long-term side effects?
Yes.
Is that a question? Yes.
Or make it yes, or make it easier.
Make it easier.
And what are the long-term effects as well?
Uh-huh. Right. So there are certain long-term side effects that we can see with the use of radiation and chemotherapy. Some of them are sometimes related to memory issues and fatigue issues. And there's not a single medicine that is extremely helpful to revert these symptoms, but in general, what we'll try to do is to recommend strategies to improve the overall health, like physical therapy is very important to improve not only physical condition, but also cognitive function. This has been seen in other diseases like dementia. So physical therapy is an important component. And then some people can also get benefit from cognitive rehabilitation.
Thank you. I think our last question is asking about the Temodar cycle, saying that you mentioned 4 weeks, and they were wondering that they had heard you could also be given Temodar daily during radiation and then shift to 1 week on and 3 weeks off. Is that a typical variation in the regimen for Temodar?
Yes, that's exactly correct. I did not go into a lot of details because it would really take long to explain every single chemotherapy regimen. But the typical treatment with temozolomide for glioblastoma involves using Temodar daily during radiation for 6 weeks at a lower dose than what is used later. Later, patients start cycles of chemotherapy that involve 5 days of taking temozolomide at a higher dose than the dose that they were taking during radiation, and then 3 weeks of rest.
Thank you. I think that's all the time that we have for today. Thank you all for joining us, and thanks once again to Dr. Penas-Prado for her wonderful webinar presentation. Besides our free educational webinars, the ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, please visit ABTA's website at www.abta.org or call the ABTA Care Line at 1-800-886-2282. We also would like to thank Arbor Pharmaceuticals for sponsoring this webinar. Let's just pause for a moment so I can conclude our recording.